Welcome to the Hospital Medicine Unplugged podcast. Today we are undertaking a highly focused clinical review regarding the evolving recognition and the inpatient management of transthyretin amyloid cardiomyopathy.
Right, commonly known as ATTR-CM.
Exactly. We are drawing upon a synthesis of recent cardiovascular society guidelines, prospective population-based screening trials, and landmark therapeutic data, such as the ATTR-ACT trial. For hospitalists, cardiologists, and frontline clinicians managing complex cardiovascular disease on the wards, this represents an essential update.
It really is. Historically, we were taught to relegate ATTR-CM to the very margins of our differential diagnoses.
We were.
It was dismissed as an exceedingly rare infiltrative condition, a so-called zebra, encountered almost exclusively in highly specialized academic referral centers. But that historical assumption has been strictly invalidated by contemporary epidemiological data.
Invalidated completely.
Yes. We now definitively recognize ATTR-CM as a major hidden driver of heart failure, particularly in our aging inpatient populations. Our objective for this discussion is to equip you, the practicing clinician, with the precise diagnostic algorithms, the subtle clinical red flags, and the critical management pitfalls necessary to identify this disease.
And we want to focus specifically on your HFpEF patient populations.
Correct. We need to provide you with the clinical framework to prevent misdiagnoses and avoid the devastating consequences of delayed interventions, especially now that we have disease-modifying therapies that are highly dependent on early initiation.
So to ground this data, let us consider a hypothetical yet highly typical patient presentation that you might see on your rounding census today.
A case study of sorts.
Right. Imagine an 80-year-old male admitted for his third acute heart failure exacerbation this year. He has a preserved ejection fraction, a thickened left ventricle on his admission echocardiogram, and a presumed history of hypertensive heart disease.
We see this exact profile constantly.
We do, and we often accept this presentation at face value. However, we need to completely rethink how we view ATTR-CM in this specific demographic. The idea that it is just a rare condition is completely outdated. What do the current prevalence metrics actually show us when we look closely at this population?
The shifting epidemiological data provides staggering metrics that must alter your clinical approach. When we specifically examine older patients defined in the literature as those over 60 years of age who present with HFpEF and demonstrate increased left ventricular wall thickness on imaging, the prevalence of ATTR-CM ranges from 6 to 17%.
6 to 17%. That is a massive proportion of an inpatient census.
It is massive. If you are managing a busy inpatient cardiology service or a general medicine ward, a significant fraction of your older patients with a thick ventricle are harboring unrecognized amyloidosis. It is not simply hypertensive remodeling.
That age-dependent escalation is profound, and it warrants immediate integration into our daily clinical vigilance.
Absolutely. The data demonstrates that in the sixth decade of life, the prevalence sits at approximately 5% among this cohort. However, as the patient demographic ages into their ninth decade, that prevalence escalates dramatically to 20%.
20%.
Yes. For the clinician managing the ward, you must internalize what this means. 1 in 5 of your octogenarian patients presenting with HFpEF and a thickened left ventricle has ATTR-CM. This is no longer a marginal consideration. It is a primary differential diagnosis that mandates active investigation.
Right, and to further contextualize the urgency here, we must address the significant screening gap currently existing in standard clinical practice.
The diagnostic gap is severe.
A recent prospective population-based study provides a sobering metric regarding our collective diagnostic acumen. When systematic screening utilizing technetium-pyrophosphate scintigraphy is deployed across a population, it detects approximately 6 times more ATTR-CM cases than routine symptom-driven clinical diagnosis alone.
A 6-to-1 ratio.
A 6-to-1 ratio. That implies a massive failure rate in our current unprompted diagnostic workflows.
A failure rate of that magnitude forces us to ask how many cases are currently walking through the hospital doors, being diuresed, discharged, and readmitted for recurrent exacerbations, all while remaining completely undiagnosed.
Exactly.
The implications are severe. Without protocolized screening or a highly attuned index of clinical suspicion, we are merely managing the downstream sequelae of an unrecognized progressive infiltrative disease. We are treating the volume overload, but entirely missing the underlying pathology that is systematically destroying the myocardium.
And beyond age, we must also integrate newly recognized racial and ethnic disparities into our clinical calculus.
This is a crucial point.
The contemporary data reveals striking demographic variations, particularly concerning older Black individuals.
The statistics demonstrate a prevalence approaching 1 in 6 Black men over 75 years of age who present with heart failure and increased left ventricular wall thickness.
1 in 6. That is an extraordinary figure.
It is. It demands that you, as the evaluating physician, maintain an aggressively high index of clinical suspicion in this specific demographic. We have to close the ongoing health disparity gap in ATTR-CM diagnosis.
Because failing to actively screen this specific demographic contributes directly to a disparity in access to life-prolonging therapies. So knowing these patients are highly prevalent in our HFpEF populations, we must transition to the bedside presentation. Let us return to our hypothetical 80-year-old male patient on the ward. How is he presenting electrophysiologically?
Right, the ECG.
Generations of physicians have been trained to look for voltage mass discordance on the electrocardiogram as the pathognomonic sign of cardiac amyloidosis. We need to dissect why relying on this classic teaching is actually a diagnostic trap.
Well, the concept of voltage mass discordance is physiologically sound in theory.
Yeah.
If you have a combination of demonstrably increased left ventricular wall thickness on an echocardiogram, paradoxically paired with low QRS voltage on the ECG.
Because the thickened myocardium is not true muscular hypertrophy.
Exactly. It is inert amyloid fibril deposition. Because amyloid is an extracellular proteinaceous deposit, it does not generate electrical activity. Therefore, the physical mass of the ventricle increases, but the surface voltage drops or remains low.
Recognizing this discordance should absolutely raise your clinical suspicion.
It should, but it cannot be used as a mandatory screening criterion.
And the specific trial data regarding this electrocardiographic teaching clearly illustrates the danger of relying on it. Low voltage on the ECG is only present in 25 to 40% of confirmed ATTR-CM cases.
That is a startlingly low sensitivity.
It really is. It means that if you are waiting for low voltage to trigger your diagnostic workup, you will completely miss 60 to 75% of your amyloidosis patients. You simply cannot rule out ATTR-CM because the patient maintains normal or even elevated QRS voltages on their baseline admission ECG.
Precisely. And because the cardiac manifestations like the ECG can be diagnostically elusive or insensitive, we must pivot our focus to the crucial extracardiac clues.
The systemic nature of the disease.
Transthyretin amyloidosis is fundamentally a systemic disease. The transthyretin transport protein becomes unstable, misfolds, and deposits in areas of high mechanical stress throughout the body. This soft tissue infiltration often precedes significant deposition in the myocardium by years, or even decades.
The data shows that approximately 80% of individuals ultimately diagnosed with ATTR-CM have a history of preceding orthopedic interventions.
80%.
Yeah.
That is why integrating a retrospective orthopedic history into your standard cardiovascular history taking is no longer an optional add-on. It is a mandatory component of the HFpEF evaluation.
The specific timeline and manifestations of these orthopedic clues follow a highly structured pattern. Carpal tunnel syndrome is the most prominent historical marker.
Yes, caused by tenosynovial infiltration of the flexor retinaculum.
Right, and it critically manifests 5 to 10 years before the cardiac diagnosis becomes apparent. Furthermore, the history frequently reveals bilateral carpal tunnel release, which is highly atypical for standard occupational or repetitive strain injuries.
Exactly. And alongside bilateral carpal tunnel syndrome, the patient's history should be rigorously queried for lumbar spinal stenosis requiring surgical laminectomy, as well as spontaneous biceps tendon rupture.
The biceps tendon rupture often presents historically as a sudden Popeye muscle deformity in the upper arm.
Yes. You must also inquire about trigger finger. When our hypothetical patient presents with HFpEF, a thick left ventricle, and a surgical history revealing a bilateral carpal tunnel release a decade ago, followed by a laminectomy for spinal stenosis, the diagnosis of ATTR-CM must immediately move to the absolute top of your differential.
So moving from the patient's history to their functional imaging, the traditional echocardiographic assessment of simply measuring septal wall thickness must be augmented by advanced strain imaging.
The echocardiographic hallmark of cardiac amyloidosis is the apical sparing strain pattern.
We need to clearly define the mechanism of this specific finding for the clinician. Why does the echocardiogram show this distinct regional variation in myocardial mechanics?
Well, as amyloid fibrils infiltrate the myocardium, they do so with a highly specific spatial predilection. The fibril burden heavily infiltrates the basal and midventricular segments of the left ventricle while relatively sparing the extreme apex.
And the exact hemodynamic and local shear stress mechanisms for this distribution remain a subject of investigation.
They do. But the imaging manifestation is entirely clear. Consequently, speckle tracking echocardiography will demonstrate severely reduced longitudinal strain, meaning profoundly impaired active contractility and tissue deformation in the basal and mid-left ventricular segments, alongside preserved or even hyperdynamic strain at the apex.
Visually, on the echocardiogram's polar map, this creates the classic cherry-on-top pattern, where the red, healthy strain is isolated to the center, surrounded by pale, abnormal basal segments.
Yes, and to objectify this visual pattern, the literature provides a highly robust quantitative metric that clinicians should actively look for in the formal echocardiography report.
When the longitudinal strain of the apical segments is divided by the sum of the strain from the basal and mid segments, a ratio of greater than 1 is strongly indicative of the disease.
That ratio is a critical tool. An apical divided by basal plus mid ratio greater than 1 yields a 93% sensitivity and an 82% specificity for cardiac amyloidosis. It transforms a potentially subjective visual impression of the polar map into a precise, actionable diagnostic parameter.
So once clinical suspicion is appropriately elevated through these epidemiological risk factors, the striking orthopedic historical clues, and the apical sparing pattern on echocardiography, we must progress to the modern diagnostic algorithm.
The diagnostic landscape for this disease has undergone a complete non-invasive revolution over the past decade.
Historically, definitively confirming cardiac amyloidosis required an invasive right ventricular endomyocardial biopsy,
Which carried inherent procedural risks.
Exactly, risks such as perforation, and it suffered from potential sampling errors if the biopsy forceps pulled tissue from an area with sparse amyloid deposition. Today, the cornerstone of modern diagnosis has shifted entirely to nuclear scintigraphy, specifically technetium-99-meter pyrophosphate or PYP scintigraphy.
The mechanistic role of PYP scintigraphy is to detect the specific presence of transthyretin amyloid fibrils within the extracellular matrix of the myocardium. The technetium radiotracer, originally designed decades ago for bone imaging, exhibits a strong, highly specific affinity for microcalcifications that are uniquely interspersed within ATTR deposits.
And the diagnostic threshold is strictly defined by the degree of cardiac radiotracer uptake relative to standard bone uptake, specifically the ribs.
A positive diagnostic study requires either grade 2 or grade 3 cardiac uptake.
To clarify those specific grading criteria for the listener, grade 2 indicates that the radiotracer uptake in the myocardium is visually equal to the uptake in the surrounding ribs. Grade 3 indicates that the cardiac uptake is significantly greater than the rib uptake, often with the ribs appearing entirely washed out on the planar imaging due to the massive myocardial avidity.
Right. However, demonstrating grade 2 or grade 3 uptake on a PYP scan is not, under any circumstances, sufficient to definitively diagnose ATTR-CM in isolation.
This is perhaps the most critical pitfall in the entire diagnostic pathway.
I cannot emphasize that limitation enough. We must thoroughly dissect the mandatory rule-out step, frequently referred to in the guidelines as the dual testing strategy. Relying on PYP scintigraphy alone is fundamentally dangerous.
Because it can yield false positive results in the setting of light chain, or AL amyloidosis.
Therefore, there is an absolute clinical necessity to perform a comprehensive monoclonal protein screen simultaneously with the PYP scan. This screen must include 3 specific, non-negotiable laboratory tests: serum-free light chains, serum immunofixation, and urine immunofixation.
And the clinical rationale for this mandatory dual testing strategy is rooted in a highly alarming statistic. Approximately 1/3 of patients with AL amyloidosis can demonstrate positive bone scintigraphy that perfectly mimics the grade 2 or grade 3 uptake seen in ATTR-CM.
1/3. So if you simply order the PYP scan, see a grade 3 result, and conclude the diagnostic workup, you are risking a catastrophic medical error. You must prove the absence of a plasma cell dyscrasia before confirming transthyretin amyloidosis.
The statistical reliability of this combined approach is profound. The comprehensive monoclonal protein screen is over 99% sensitive for AL amyloidosis.
This means if the serum-free light chains show a normal capital lambda ratio and both the serum and urine immunofixation show no monoclonal spike, you effectively excluded AL amyloidosis.
Only when a patient demonstrates grade 2 or grade 3 PYP cardiac uptake combined with a strictly negative monoclonal protein screen does the positive predictive value for ATTR-CM reach 100%.
In that specific dual testing scenario, The combined approach achieves an overall 99% sensitivity and an 86% specificity for ATTR-CM.
If you omit the monoclonal protein screen, you risk misdiagnosing a patient with AL amyloidosis as having ATTR-CM. AL amyloidosis is a severe hematologic emergency requiring immediate, aggressive chemotherapy.
Delaying that treatment because you falsely assumed they had the slower progressing ATTR variant based on a single nuclear scan is an invariably fatal error.
So once the diagnosis of ATTR-CM is definitively established via this rigorous algorithm, the clinical focus shifts immediately to disease-modifying therapies.
This is a rapidly evolving field that has completely transformed this diagnosis from a purely palliative end-stage condition into an actively treatable one.
Based on the provided historical trial data, tafamidis is highlighted as the sole FDA-approved therapy. Tafamidis operates mechanistically as a transthyretin stabilizer.
It binds precisely to the thyroxine-binding sites of the native TTR tetramer, preventing its dissociation into the unstable amyloidogenic monomers that ultimately misfold and deposit in the myocardial tissues.
The landmark ATTR-ACT trial provided the foundational efficacy data for this stabilizing agent, and the results fundamentally changed cardiovascular practice.
The trial was a rigorous multi-center evaluation involving 441 participants. The outcome data is highly compelling.
Continuous treatment with tafamidis demonstrated a 30% relative reduction in all-cause mortality, dropping the mortality rate from 42.9% in the placebo group down to 29.5% in the active treatment group over the trial period.
A 30% relative reduction in mortality is an outcome we rarely achieve in this specific demographic with standard cardiovascular interventions. Furthermore, the trial demonstrated a 32% relative reduction in cardiovascular hospitalizations, reducing the rate from 0.7 per year to 0.48 per year.
To translate those percentages into actionable clinical metrics for the practicing physician, we look at the number needed to treat.
The NNT is highly favorable. You need to treat only 7 to 8 patients over a 30-month period to prevent one death.
However, there is a crucial physiological caveat within that trial data that mandates absolute urgency in our inpatient diagnostic workflows. The ATTR-ACT trial demonstrated that the therapy has far greater efficacy in earlier stage disease, specifically in patients presenting with New York Heart Association Class 1 and Class 2 heart failure symptoms.
Because transthyretin stabilizers only prevent further monomer dissociation and subsequent amyloid deposition, they do not possess the ability to extract existing organized amyloid fibrils from the extracellular matrix of the myocardium.
Because they cannot reverse existing structural damage, initiating therapy after the patient has progressed to NYHA Class 3 or Class 4 heart failure yields severely diminished returns. The restrictive physiology is already entrenched.
Therefore, early intervention is not merely an optimal clinical strategy. It is the sole window for meaningful disease modification. It is also necessary to note the emergence of newer options in the therapeutic landscape. Acoramidis, a newer, highly potent TTR stabilizer, received FDA approval in 2024.
That recent approval was supported by the ATTR-CM trial, which demonstrated similarly robust benefits regarding both mortality and cardiovascular hospitalization reductions. The introduction of multiple disease-modifying agents underscores the expanding therapeutic arsenal available to the clinician,
further reinforcing the absolute necessity of early and accurate diagnosis.
Now, for the purpose of strict clinical differentiation, we must briefly contrast this with the treatment for AL amyloidosis to reinforce why the monoclonal screen is paramount.
As previously mentioned, AL amyloidosis is fundamentally driven by a clonal plasma cell dyscrasia. Its management is entirely different and falls strictly within the purview of hematology oncology.
The treatment targets the underlying bone marrow clone, producing the toxic light chains. Currently, daratumumab-based regimens have emerged as the preferred first-line therapy.
Other options include bortezomib-based combinations and, for highly selected robust patients, autologous stem cell transplantation.
It is a vital clinical reality to note that only 20 to 25% of newly diagnosed AL amyloidosis patients are eligible for autologous stem cell transplant.
This low eligibility is primarily due to the severe advanced cardiac involvement that is often present at the time of diagnosis, which renders them too hemodynamically fragile to survive the conditioning regimens.
This stark contrast in therapeutic pathways and sheer urgency reiterates exactly why the diagnostic monoclonal protein screen cannot be bypassed under any circumstances.
So returning our focus to the daily management of the confirmed ATTR-CM patient on the hospital ward, We must meticulously examine the perils of standard heart failure therapy.
We established earlier that these patients universally present with HFpEF. However, the standard guideline-directed medical therapy that we reflexively prescribe for routine heart failure is fundamentally flawed and often overtly dangerous in this specific population.
The physiological challenges of treating amyloidosis-driven HFpEF stem entirely from their profound restrictive physiology.
We need to profoundly explore that pathophysiology to understand the bedside management. The left ventricle is heavily infiltrated by extracellular amyloid fibrils, rendering it incredibly stiff and non-compliant.
If we visualize the Frank-Starling curve for this ventricle, it is shifted severely downward and rightward, becoming incredibly steep.
Because the ventricular cavity is small and the walls cannot relax during diastole, the stroke volume is severely restricted, and crucially, it becomes relatively fixed.
The ventricle cannot augment its stroke volume in response to increased demand or stress.
Because the stroke volume is fixed and cannot increase, the patient's entire cardiac output becomes exquisitely and completely dependent on their heart rate.
This unyielding physiological reality explains exactly why standard, heavily prescribed therapies like beta blockers, ACE inhibitors, and angiotensin receptor blockers are so poorly tolerated. They may actively worsen the patient's hemodynamic status and precipitate clinical decline.
Let us walk through the exact hemodynamic collapse that occurs if you administer a beta blocker to one of these patients on the ward. By giving a negative chronotrope to a patient with a fixed stroke volume, you are pharmacologically removing their single remaining compensatory mechanism, tachycardia.
Without the ability to maintain a higher heart rate, their cardiac output plummets instantly. This precipitous drop rapidly induces severe low-output heart failure, renal hypoperfusion, and can easily spiral into profound cardiogenic shock right there on the medical floor.
Similarly, the autonomic neuropathy that frequently accompanies systemic amyloidosis makes these patients highly susceptible to the vasodilatory effects of ACE inhibitors and ARBs.
The amyloid infiltration of the autonomic nervous system blunts their sympathetic tone. When you introduce an afterload-reducing agent, they cannot mount a compensatory vasoconstrictive response.
This frequently results in profound refractory orthostatic hypotension, recurrent syncope, and end-organ hypoperfusion.
Therefore, the clinician managing these patients is left walking a continuous, highly precarious volume management tightrope. The reliance on loop diuretics becomes the absolute mainstay of daily inpatient therapy to manage their congestive symptoms and elevated filling pressures.
However, these patients exist within a remarkably narrow window of euvolemia, and titrating these diuretics requires microscopic attention to daily weights, strict intake and output monitoring, and serial physical examinations of the jugular venous pressure.
If you underdiurese the patient, the required high filling pressures in the stiff non-compliant ventricle rapidly transmit backward into the pulmonary vasculature, causing severe pulmonary edema, hypoxia, and systemic venous congestion, leading to hepatic engorgement and ascites.
Conversely, if you are overly aggressive and overdiurese even slightly, you drop the right-sided preload.
Because the restrictive left ventricle requires abnormally high filling pressures just to maintain adequate end diastolic volume and stretch, dropping the preload immediately collapses their already marginal stroke volume.
That drop in stroke volume leads to devastating sudden hypotension and systemic hypoperfusion. A routine 20 milligram intravenous push of furosemide, which a standard heart failure patient would easily tolerate, might precipitate an acute kidney injury or a syncopal event in an ATTR-CM patient.
In addition to the careful millimeter-by-millimeter titration of loop diuretics, there are strict pharmacological contraindications that must be observed to avoid severe iatrogenic harm on the wards.
Beyond beta blockers, non-dihydropyridine calcium channel blockers, such as verapamil and diltiazem, are strictly contraindicated.
Like beta blockers, they exert potent negative inotropic and chronotropic effects that are lethal in a restrictive physiology.
Even more uniquely, we must specifically discuss the severe dangers of utilizing digoxin for rate control in this population.
Yes. Digoxin must be entirely avoided in cardiac amyloidosis because the medication possesses a unique affinity to bind directly to the extracellular amyloid fibrils themselves.
That fibril binding mechanism is a critical physiological trap. Because the digoxin binds directly to the massive burden of amyloid fibrils within the myocardium, the localized tissue concentration of the drug increases dramatically.
This leads to severe, life-threatening cellular toxicity and fatal arrhythmias. even when the patient's measured serum drug levels appear entirely within the normal accepted therapeutic range on your morning lab panel.
The serum level completely misrepresents the toxic myocardial tissue level.
Another highly critical nuance in the inpatient management of these patients involves anticoagulation strategies, specifically concerning the management of atrial fibrillation.
Atrial fibrillation is exceedingly prevalent in this population due to the progressive amyloid infiltration and subsequent dilation of the atria. The standard universal teaching for determining stroke risk and initiating anticoagulation in atrial fibrillation relies heavily on calculating the CHADS-VASc score.
However, a vital clinical pearl for the hospitalist is that in the specific setting of cardiac amyloidosis, the CHADS-VASc score is completely and entirely irrelevant. You must ignore it.
Formal clinical guidelines recommend that anticoagulation, typically with a DOAC or warfarin, is formally indicated for these patients regardless of their calculated CHADS-VASc score. Even if their score is 0, if they have ATTR-CM and any history of atrial fibrillation, they must be anticoagulated.
The underlying pathophysiology behind this absolute rule is grounded in the unique structural and functional destruction of the amyloid-infiltrated heart. These patients face a severely elevated thromboembolic risk that operates fundamentally independent of traditional risk factors like hypertension or diabetes.
The heavy amyloid infiltration of the atrial walls leads to severe electromechanical dissociation and profound, irreversible atrial stasis.
This severe mechanical stasis creates a hemodynamic environment that is highly conducive to the rapid formation of intracardiac thrombi, particularly within the left atrial appendage.
Crucially, we must emphasize that this severe stasis and the subsequent generation of these thrombi can occur even when the patient remains in normal sinus rhythm on the telemetry monitor.
The mechanical failure of the atrium frequently precedes the overt electrical failure.
Therefore, if a patient with established ATTR-CM develops even a brief, transient episode of atrial fibrillation on telemetry, standard risk stratification protocols are bypassed entirely. Lifelong anticoagulation is immediately mandated to prevent catastrophic embolic strokes.
To consolidate all of these complex diagnostic and inpatient management principles into actionable quantitative tools for the wards, we should review the specific clinical pearls regarding scoring systems and biomarker exclusion criteria.
The recent literature provides the ATTR-CM score, a highly validated tool which ranges from -1 to 10. This score utilizes a weighted combination of clinical variables, such as age and sex, electrocardiographic variables, and specific echocardiographic parameters to estimate the pretest likelihood of the disease.
A calculated score of 6 or greater yields a 93% sensitivity and a 62% specificity for ATTR-CM. This provides a very strong, objective, quantitative basis for pursuing definitive nuclear scintigraphy.
Equally important for the practicing clinician is the ability to confidently exclude the disease in lower-risk inpatient populations. This is essential to prevent unnecessary, costly, and time-consuming advanced testing.
The data provides highly specific biomarker thresholds for safe clinical exclusion. In patients with a low pretest clinical suspicion, a severely depressed natriuretic peptide and troponin profile can effectively rule out the infiltrative condition entirely.
Specifically, if the patient has an NT-proBNP of less than 180 nanograms per liter, combined with a high-sensitivity troponin T of less than 14 nanograms per liter, this profile holds excellent negative predictive value.
If your HFpEF patient meets these strictly defined biomarker criteria, you can safely exclude ATTR-CM from your active differential diagnosis without proceeding to advanced resource-intensive nuclear imaging.
This brings us to the core takeaway for the clinician managing cardiovascular patients today. The overarching lesson is one of heightened systematic vigilance and strict pattern recognition.
When a patient's HFpEF presentation does not completely align with standard expectations, particularly if they exhibit unexplained left ventricular hypertrophy, the classic but highly insensitive voltage mass discordance on their ECG, or a highly suggestive retrospective history of specific orthopedic procedures like bilateral carpal tunnel release or lumbar spinal stenosis, cardiac amyloidosis, must be immediately elevated to the top of your differential diagnosis.
Early diagnosis is absolutely not an academic exercise. It is an absolute clinical necessity. The life-prolonging, disease-modifying therapies we discuss, such as tafamidis and acoramidis, are heavily dependent on early initiation before irreversible structural and restrictive damage occurs within the myocardium.
If you wait until they are in end-stage refractory heart failure, The therapeutic window has permanently closed.
I will leave you with a final, provocative clinical challenge to ponder as you return to your rounding duties. We have extensively discussed the systemic, protracted, multi-decade timeline of this disease. As our electronic medical records become increasingly sophisticated and integrated, how might we eventually automate the synthesis of these widely disparate clinical data points?
Imagine a future EMR algorithm that automatically identifies an isolated orthopedic procedure code for a bilateral carpal tunnel release from 10 years ago, cross-references it instantly with a borderline echocardiogram demonstrating increased septal wall thickness today, and immediately triggers an urgent alert for the attending physician.
This alert would prompt early screening before irreversible restrictive heart failure ever sets in. Connecting these seemingly unrelated dots across a decade of a patient's life is the ultimate clinical frontier in eradicating the delayed diagnosis of ATTR-CM. Thank you for your rigorous attention to this complex, unforgiving, and rapidly evolving pathology.